the project, as Abby said, it's exploring the psychosocial drivers of shisha smoking and patterns of use in Birmingham. And I'll sort of just talk through, again, that rationale and what we did and what we found. So shisha use, it's also known as hookah, nagar, waterpipe, and it essentially involves smoking flavoured tobacco through a water-based apparatus. It's common in the Middle East and South Asia, and it's becoming increasingly popular in Western countries. Shisha use has been described by the World Health Organization as an epidemic, as it's kind of overtaken smoking behavior and in some countries, and it's being increasingly used by men, women, and children. So this is sort of a growing issue here. It's emerging. Shisha itself, using shisha is legal in the UK, so it can be purchased legally in shisha premises, and it can also be purchased privately, so people can use it in their own homes as well. There isn't specific legislation looking at just shisha alone, but it's regulated using different bits of legislation, so Health Act, tobacco and related products regulations, health and safety at work, and trading standards. So we know it's emerging. What do we know in terms of prevalence? We know very little. So there's, it's not regularly surveyed, so we don't know what shisha use is, but there are studies that have been conducted that can give us some insight into shisha use. So there was a study conducted, published in 2017, which indicates about 1% of the British adult population has smoked shisha once or twice a month, with between 11 and 13% ever trying shisha. Various studies, it's quite mixed, the results are. There isn't a specific definitive group that is more likely to try shisha, because studies show different things. But generally, the evidence indicates younger generations, certain minority ethnic groups, males, existing cigarette smokers, and those from a higher socioeconomic status use shisha. The cost of shisha is quite high in comparison to cigarette smoking, so I can see why it's linked to that higher SES. You would need disposable income to be able to consume shisha regularly. But in terms of, so that's national data, but in terms of Birmingham data, it's quite limited. There's unclear usage patterns across different ethnic groups. And again, various studies and, university samples have found that, just over a third will have tried shisha, a fifth will have used it monthly, and that increases the more time they spend at university. 15-year-olds in Birmingham have tried, and they would have ticked tobacco products such as shisha, so that might have included other things. And also there was another study that identified 16 to 24-year-olds as shisha users. So why is this a problem? Shisha itself, it's perceived as a harmless social activity, but actually there are significant health risks that are sometimes misunderstood. So, research has shown that there are high levels of carbon monoxide for shisha smoke, that they're up to 35 times higher than cigarette smoking. And it also has higher levels of other toxins or cancer-causing chemicals. And also sort of being in non-ventilated areas as well might sort of, increase that risk. So generally, the shisha risks are known in this way, that they're linked to heart and circulatory diseases, respiratory issues, infectious diseases. There are some addictive elements to it because of the nicotine, secondhand smoke risk, and then of course the social and economic costs associated with smoking shisha as well. So I guess we have a situation where we know that shisha use is on the increase. Don't really know what's going on in Birmingham or even more broadly, but what we do know is that shisha, people believe that shisha itself is safer than smoking cigarettes, because of the water filtration is some of the reason, the fruity flavors, it's got these positive associations, but it has all of these health risks. And so it's about aligning public health support in a way that matches people's beliefs and promoting protective health behaviours. And again, there is all the indications here that people might be engaging in a behaviour that they don't believe is harmful. So the aim of this project then was to explore the psychosocial drivers of shisha use in Birmingham. So this is, specifically we were looking at who is using shisha, where, when, and how, and which psychosocial factors predict frequency of shisha use. So again, this is about getting that localized data on these sort of drivers of behavior so that we can get those localized insights to identify how they can be addressed appropriately through feature-based evidence interventions. So that's sort of what led us to the project aim. In terms of what we did a cross-sectional online survey. So it was a questionnaire that had been set up on Question Pro. Data collection was open between July and September 2025. It took about 5 minutes to complete. The inclusion criteria was anyone aged 12 years and older, because there was evidence of underage use in some previous insights work. People just needed a proficient use of English to complete the survey, and they needed to either be a current or previous, they needed to have either used Shisha previously or they were a current user. So it wasn't a requirement that they were currently using Shisha, it was just that they'd used Shisha at least once in Birmingham. The recruitment strategy was a huge effort from lots and lots of people, but we tapped into online regional networks, went to shisha lounges directly. There was face-to-face recruitment activity and lots of local events, so sort of tried to do the both active and passive recruitment strategies so that we could include as many participants as possible across the region. What did we measure? So we measured shisha use as defined by frequency, modality, duration, context, and location. We looked at different motivations for shisha use, the role of peer and family influence, different types of risk perceptions, so experiential, as in their own experience, and comparative in terms of how it compares with other health risks, smoking cessation, addiction, and then some demographic details, and we used the ONS categories to compile those. What we did was we developed the measures using a combination of what already exists, primarily in the smoking domain, smoking cigarettes area, but they were adapted, or we created some new measures, new questions based on wider literature and also subject expertise. And then in terms of data collection, we managed to get 5,474 views. 388 people started to complete the survey, and in terms of usable data, people who completed enough questions, we had 167 questionnaires. So the results that I'm going to share with you are based on 167 respondents, but of course all of those all of those views of the front page of the survey, or even the survey itself, didn't translate into 5,000 survey responses, unfortunately, but 167, which we were pleased with. It was our recruitment target, so we were pleased with that. So of course the next few slides will be around the results, and these are descriptive results, and it's going to give us some insight into who is using shisha, and again that question of where, when, and how. So in terms of the demographics then, and these are our participants who completed the survey, but it gives us an indication of who's using shisha in Birmingham. Participants were aged between 13 to 69 years of age, and the mean age was 27 years. 5 of those participants were under the age of 18. So there is again, it's confirmatory in the sense that this confirms there is some underage use of shisha in Birmingham. And although previous literature has shown that there are a high number of male users, we actually got 60% of this sample were female respondents, and the pie chart there gives you a breakdown of the different categories. So we did a large number of female respondents. In terms of background, so nationality-wise, the highest was British, followed by English. Ethnic groups, the highest group was Pakistani, followed by Bangladeshi, and then white. The pie chart there shows you actually just how many different groups, although there weren't large numbers, there were people from lots of different backgrounds that completed the survey, indicating they used shisha. And in terms of religion or faith, the Muslim group was the highest, followed by no religion, and then Christian groups. And we did have a small number of respondents from Sikh, Jewish, and Buddhist faiths as well. The majority of participants were not married. So again, that's what the pie chart relates to there, followed by married, divorced. So I think it's 64% were not married, followed by a quarter that were married, and sort of in various different the relationship statuses. In terms of employment status, more participants were in full-time employment. So it's about 44% were in full-time employment, followed by part-time work and part-time education and part-time work. And highest level of education varied, but the highest number of respondents had either a college or sixth form education or a university graduate or university graduates. So again, this just sort of gives you an idea of who is using Shisha in Birmingham, and you can see it's quite varied. In terms of the regional data, you know, where are people using Shisha? Less than half of our participants provided regional data, so only 48% responded to the question about whereabouts in Birmingham they live, or whereabouts they live. But from the data available, we couldn't link a specific ward with higher use. So as you can see, these numbers, you know, the first few numbers, at least, they don't hugely differ, but we can see more participants lived in East Birmingham, followed by South Birmingham, City Centre, West Birmingham, and North Birmingham. Of course, there are still lots of things that will need to be tested following this that we couldn't answer, but we did wonder if North Birmingham had fewer responses because most of the Shisha lounges are potentially located in the city centre. But as I say, this is largely descriptive. Where does Shisha use occur? So for most people, this is 87% of participants use Shisha in cafes or lounges, followed by at home, which is 28%, or then somebody else's house at 13%. And where, so in terms of those cafes and lounges, so those 87% of participants that responded, they use Shisha in lounges in Digbeth, followed by Sparkhill, City Centre, and then Moseley. Those were the sort of the highest number, you know, in terms of the areas where Shisha use was occurring in Birmingham. How is Shisha being used? So single pipe Shisha was the largest modality, 67%, followed by vaping and then smoking. And the majority of participants use Shisha with their friends. It was 92%. So again, it confirms a lot of what the previous literature has shown. But although there is this large sort of social function in terms of being with friends and using Shisha, family, using Shisha with family and alone was also the context for more than half of the participants, with 32% for family and alone for 20%. So it can vary. How often is Shisha used? So frequency varied. Some participants use Shisha every 2 to 3 months. Others use it weekly and monthly. And again, the percentages were very minimal between those. But there are 12% that use it daily. And then we have those who use it less frequently, maybe once a year or every 6 months. How long do people use Shisha once they've started? So most participants have been using Shisha for more than a year. And I think the largest proportion indicates more than 5 years. Yeah, 5 years plus. So 31% have been using Shisha for 5 years plus, followed by 2 to 5 years at 28%, and then 1 to 2 years at 26%. So this is a behaviour that does go beyond experimental and, you know, exploratory. You know, it's sustained over a period of years, but that's what the data would indicate. And how long do people use Shisha for? So a single Shisha session duration in this sample ranged from 1 to 2 hours for most participants, followed by 30 minutes to an hour. And then there is a smaller proportion that will be in a Shisha session for 16%. Now, of course, that might not be them consuming Shisha continuously for 2 hours. There might be that social function where there will be a break, but there is still a lot of exposure to some of those health harms over that period. Who are our highest Shisha use groups? This is based on descriptive data. So yeah, I guess it's just not wanting to overstate the findings, but at the same time, just sharing with you where the highest number of responses were based on frequency of Shisha use. So these are individual groups, but what we found was that 31 to 50-year-olds, females, English, white, never married or divorced, in the those in education and at a postgraduate level, and no religion groups had the highest frequency of Shisha use. In terms of number of years of Shisha use, the highest was in the 41 to 50 years, those in the who are white, married and in employment. Session duration didn't really vary a lot between groups. There wasn't much in it. And the addiction scores were higher for Bangladeshi and those in both employment and education simultaneously, and Muslim groups. So there's something about frequency being high in certain groups, but addiction scores indicating that they're higher in other groups. But again, this is descriptive data. So this is the kind of thing that where more work would be needed, but we can see there's a these insights are helpful, but we would need to do a little bit more work to say with certainty what that relationship looks like. So that bit of data there speaks to, who is using Shisha, where, when, and how. The next section of these results are around those psychosocial influences on Shisha use, those drivers of behaviour, those influences, whether they are internal or external to the individual, that determine whether or not they go on to use Shisha. And that's what I'll share with you now. Now, actually, interestingly, peer and family influence people did not perceive as something that pressured them to use Shisha. So for both family and friends, in terms of the response, do they encourage you to use Shisha? Most people said never and rarely, although a small proportion did indicate often or always, but very small. And equally, did people feel they needed to use Shisha for social acceptance? And the majority either strongly disagreed or disagreed. But again, there was a small proportion that said they agree or strongly agree. So while for most people they did not perceive the pressure, there is some element of peer and family pressure for a smaller number. In terms of smoking cessation, we had 2/3 of participants hadn't actually tried to stop using Shisha. So most people said they hadn't tried to stop, but of those that had tried to stop, 62% managed to quit for months, compared to a smaller proportion that had managed to quit for weeks, and then even less and less. We were on sort of 6 people had said they'd managed to stop for a few days, and 3 people had said they managed to stop for 1 day. So we put, there was a question asking, well, did anything make it difficult in your quit attempt? And friends and stress were the highest number of reasons given, followed by there being no support services and work and family. Those were the reasons people found it difficult, to that third who had tried to quit. In terms of healthcare use, so most participants hadn't visited a doctor or a healthcare provider to try and quit using Shisha. I guess you'd have to perceive it's a problem, but 94% hadn't, and over half had indicated that if this service was available, they probably wouldn't use it. So that's something to think about in practical terms. If this provision is made available, actually work would need to be done before that to make people see the value in it. It isn't just a case of provide the service and it will be used. An intention to quit varied. So just under half of participants weren't interested in quitting. Just under a quarter said they will quit someday, but not within the next 12 months. 18% were planning to quit within the next month. And, again, an even smaller proportion were thinking about quitting within the next 12 months. So it varied. Some were interested in quitting, others were like someday, and some were not at all. So those are intentions to quit, which again are also helpful from a behaviour change point of view, because you can do work to get people to sort of start thinking about the behaviour and eventually review their intention to engage or not in that behaviour. In terms of risk perception, we looked at two different types of risk perception. Comparative risk perception, so how does it compare to other illnesses, other substances, and experiential risk perception in terms of their perceived likelihood of harm, going inwards. It's worth noting here, risk perception in terms of our inferential statistics, what was a significant predictor of shisha use. Risk perception wasn't a significant predictor of shisha use, but the descriptive data that I will share with you shows sort of mixed levels of knowledge about the likelihood of harm. So we had a high proportion that didn't know if shisha causes serious illness, and they perceived it to be less harmful. We'll talk about substances on the next slide, but what we can see here is in terms of the perception of shisha use causing different health conditions, more participants identified that shisha could cause lung cancer. So here we go, we had 60%. So in the green column, 60% said shisha can cause lung cancer and addiction, with fewer identifying this for, of course, heart attack, stroke, and infection. And we're hypothesizing here that maybe because shisha smoking is associated with smoking, cigarette smoking.
Atta, you've just gone on mute. Sorry, we can't.
Yes, I don't know what's going on here. Thank you. I have no idea what's going on with my laptop today, so my apologies. I'm going to keep my hands here so you can see I've done nothing. And I don't have Alexa, so yeah. But yeah. So the point here is, if we think about some of the legacy effects of cigarette smoking, for example, maybe some of those campaigns where people have associated cigarette smoking with addiction and lung cancer may have been transferred over to people's understanding of risk perception with shisha smoking. And then, comparative risk perception. So in terms of perception of shisha harm relative to other substances, the sort of evidence indicates that shisha use is perceived as less harmful than cigarette smoking. Followed by, let's see, so it's cigarette smoking, vaping, nitrous oxide, cannabis, cocaine, and alcohol for the highest proportion of respondents. So this is a purple pink column here. It's shisha seen as less harmful for most of those, but some participants did indicate that shisha use was more harmful or equally harmful for these substances as well. So again, it indicates mixed levels of knowledge here. Some people, the majority might not know, but there are a portion of shisha users who do know that it comes with these risks. In terms of their own personal risk, their experiential risk perception, do participants believe they have experienced illness as a result of shisha? Most said no. And again, so that was 81%, and a small proportion said yes or don't know. And then the likelihood of experiencing illness as a result of shisha was a bit more mixed. So some said not likely at all, others somewhat likely, with, again, a smaller proportion saying very likely or don't know. So again, sort of indicates mixed levels of knowledge here. And again, from a behaviour change or public health point of view, the starting point can be increasing knowledge. It's not the only thing that's going to work from a behaviour change point of view, but it's definitely one of the drivers of behaviour here. So we may have some users who aren't aware of that risk. Greg, who again, unfortunately can't be with us today, did run a series of inferential statistics on the data, so we could look at predictors of shisha use. We didn't look at ethnicity inferentially because of the unequal and limited numbers of participants in each of the groups. So, we had 90 in the Pakistani group and 15 in the Bangladeshi and 14 in the white group. So we did unequal numbers. So we didn't explore ethnicity as a driver, but we did look at other predictors, and what we found was there was no relationship between motivation to use shisha and gender, or how often participants use it and how they use it. But what we did find was that as age increases, the motivation to use shisha for excitement decreases. And you would sort of expect this theoretically as well. So younger users were more motivated by that excitement compared to those who were older. Being with friends was a high motivation for shisha use, for those who use shisha both publicly and privately, and not only privately. Participants who used shisha with other people used shisha more often compared to those who used it alone. But those who used shisha alone had been using it for longer and also scored higher on their addiction scores as well. And shisha use was more frequently used in public locations compared to those who used it both publicly and privately. And I guess that speaks to the physical social function in terms of going somewhere. Family togetherness was a higher motivation for shisha use for those who used shisha both publicly and privately, not just those who go to cafes. So again, you might use shisha in somebody's home. Addiction scores were higher for those who vaped shisha compared to smoking it. Shisha vapes are portable, aren't they? So it's probably easier just to use them. Tension release, so this is stress and coping. That was a high motivation for those who used shisha privately. And their higher addiction scores were associated with intentions to quit in the next 12 months compared to not quitting at all. And for those who did try and stop using shisha in the last 12 months, they had a higher addiction score compared to those. And that sort of speaks to this motivational paradox here. So you would think if people are trying to quit, then they will use shisha less. You know, they've got this intention. But actually, and we see this in nicotine research where those with higher addiction scores generally show higher intentions to quit within a year, because as the addiction increases, so does the recognition of its negative consequences, which then triggers more attempts to quit. So, and that came through in this data as well. So we weren't too surprised by that result. So yeah, lots of drivers here, drivers around addiction, where people use smoking, you know, whether it's public, whether it's private, you know, the motivations being, you know, excitement for the younger groups in particular, largely consistent with what we've seen in previous research. So in summary, this is, as far as we know, this is the first study in Birmingham that explores shisha use across a broad age range. You know, there's the Birmingham prevalence data I shared with you is a younger group, but this sort of goes beyond that. And what it does show is that shisha use, it isn't restricted to this young experimental phase, you know, rather it's related to ongoing consumption over several years. And again, we did have this broad group. So we've got, you know, we've now got the evidence to show people in Birmingham using shisha from a broad age range, from as young as 13 years up to 69 years, across a range of ethnicities, again, including females. So it sort of highlights the need for nuance in the approach that's taken forward. The social function of shisha was evident, although we didn't find peer influence as a predictor. Again, that social function was evident in terms of people using shisha in public places. And risk perception, again, although not a significant predictor, the descriptive data shows this mixed level about likelihood of harm, that people's knowledge of likelihood of harm, and that sort of gives us a nice foundation, if you will, in terms of the health campaigns, you know, and highlighting severity of use and, you know, increasing the perceived likelihood of experiencing these consequences. So quite often people will think, yeah, that's a problem, but it's not a problem for me. And that's a little bit of what may have come through here, is that, you know, this may be a problem for lung cancer and addiction, but it's not a problem for me in terms of that experiential risk perception score. So it's about helping people recognize the health risks and beliefs, you know, in their ability to quit. But again, it's that caution between viewing the costs associated with quitting. So, you know, there's these social factors can't be seen as too high. So if the costs of quitting are too high, then it's going to be harder for people to change this behaviour. And if the social factors are protective buffers against lots of other things, then it's that trade-off, isn't it? So it's about proceeding with caution if we're going to tell people to stop, you know, using shisha. If it serves a social function, then something else really needs to be there in its place. And there are some recommendations that I will end on, just as I'm keen to get your thoughts, and my apologies, there'll be less time for discussion with the technical difficulties. But you know, from this study, we have got some sort of initial recommendations that we think are viable here. So, you know, there's the role of health campaigns to increase awareness of shisha use, and this is about harnessing place-based assets where most shisha use occurs. And again, Birmingham City Centre, East Birmingham, is where a lot of shisha use occurs from this study. And there's visible environmental prompts, so using billboards to communicate the health risks. Again, there's place-based components. Given the nuance, it's about tailored interventions, being community and peer-led, co-designed. This is to reflect older and younger users and more diverse communities as well. This is about identifying also children's understanding and exposure to accessing shisha. So work needs to be done to identify early interventions as part of preventative health campaigns, not just, you know, quit if you started. Healthcare professional training, given those very little signposting or willingness to use these services. Again, sort of using these, it's almost like making every contact count. Making every contact count. So you know, using it as an opportunity to signpost people to services, and seeing the relevance of those services. Increasing social provision. Again, you know, if we're going to recommend people don't use shisha and they go because it achieves this social function, then actually there is then the onus on authorities to provide safe environments that offer something similar. So some sort of social provision here for people to get that protective social function that they achieve from shisha use. Routine surveillance, of course, is required to identify increase in prevalence or a shift in trends. That speaks to longitudinal research as well, because as we can see, use isn't restricted to just adolescence and young adulthood, but it's about how drivers change over time. So does it start from excitement and exploration and then move into coping with life stresses? Because a lot of people use shisha over many years. And then, of course, regulation of shisha establishments, including reminding people of the rules and consequences. So this is the enforcement around underage use, because we know it happens in Birmingham. I'd just like to take a moment to thank lots of people, because, of course, you know, the study like this was not possible without a whole team. So many thanks to the project team and the steering group at Birmingham City Council. They were phenomenal in terms of their input and their support. Thank you, Natalia, Abby, Alicia, for all your logistical support. We have some RAs at BCU and a Volunteering for Health organisation that supported with the recruitment, and of course the participants who completed the survey. So I'm going to hand over and see if there's anything. Yeah, we have got a little bit of time. Do you have any questions, any thoughts? And good to sort of hear, yeah, and I'll just catch up with the chat as well. I can see a hand up.
Yeah, Cody, do you want to come in?
Hi, it's a really interesting survey and quite detailed, very insightful, especially the part where it says like most of the people, shisha users, they do know it's very harmful for them, and they do understand it's not good for the physical health. But at the same time, they most of them said they're not going to take up the service, and even if the service is available. So that's quite interesting to observe. And I just want your comment on my previous question. Unfortunately, I can't access the chat, so I'm gonna just say it here. Is there any data on shisha only use or shisha use along with smoking or vaping? Because the pattern of shisha use is quite infrequent, and are they using anything in between? And if yes, then how a stop smoking service can support someone?
Yeah, so we don't have that data, and that would be really helpful. So because this was an exploratory study, it's very much been a starting point. If I showed you, you'll see the report. Once you see how many statistical tests had been conducted, you'll see why we just had to draw a line in terms of it being a survey that people were willing to complete. But you're right, there's something about the health profile and the current behaviors, other health behaviors, and how they interact. Because if you know, is is shisha smoking an extension of the beliefs that drive cigarette smoking? And how do they intersect and interact? So while I wish I could answer that question, we don't have that data. But you had a second part to that in terms of health services.
Like because I run a stop smoking service, and that I don't know how to support someone with patches or anything else, because that becomes an issue if someone is having once in a month shisha.
Yeah.
And as you said in your report, it says most people even do not want to take up the service. We had few clients, but obviously they are not there because of themselves. Someone forced them to sit there.
Yeah. It's about how you have those conversations to highlight the
Exactly.
risk, and then how that risk is relevant to that individual. And it's a style of communication. And this is why one of our recommendations is healthcare professional training, because it's how you navigate that. So there's one is the fact finding, and then there's the sort of increasing risk perception, and then taking action. It's a process. And as I say, this has sort of been the springboard for what we see as lots of future work that's needed in this space.
That's brilliant. Thank you so much for this very detailed research. Thank you.
Thank you.
I can see a few questions in the chat. Atia, shall we try and
Work
answer
through
a few
those
of
as well.
those?
Yeah, absolutely. So where are we? I'm going to go from the top. Slides will be shared. Chris, vaping is the portable one version, and then the hookah is the big apparatus that has the pipes. You can have a single pipe, you can have dual pipes, you can have up to 4. Yeah, brilliant. Thank you, Janet. So what links, if any, have been observed between shisha use in Birmingham and alcohol consumption among users? Similar to Mr. Singh's question there, we don't have that data, unfortunately. But again, I think there is something there. Sometimes you have a combination of behaviours, don't you? You have drinking and smoking sometimes come hand in hand. And is there something around shisha and another behaviour? And we did not have that data. So one for future research. Did the research find any evidence that shisha users do or don't view it as smoking, and therefore whether they would self-identify as smokers? That's a really good question, Chris. I think this is where we need that qualitative piece as well, that to tap into identity processes in a way that the survey couldn't. It was one of the recommendations, and for brevity, although looking at the slide, I should have kept it in. There was one more tab saying qualitative research is needed, but I think it's no, we just assumed shisha smoking. That's how they would interpret it, but I think it's worth clarifying. Shishas do, and we did have a question around smoking behaviour. So we sort of did in our risk perception questions around smoking, is shisha more or less harmful than cigarette smoking? Hopefully made it clear that this is a different behaviour, but we can only assume that's one of the limitations of survey data, I guess. And let me know if I'm not answering questions. Please jump in if you would like further clarity or context. Is there evidence of shisha use during pregnancy? Not in this study. I'm trying to go back through the literature review. I don't think it came up, and again, I don't think it's been explored. But again, if we look at the parallels, we know smoking is going down, vaping is going up. What's the journey of shisha in that? And of course, we know smoking cigarettes occurs in pregnancy. So it's an important area that warrants further investigation. There's reference to the number of people who viewed the survey but did not complete it. To what extent can we infer the individuals who viewed the survey were shisha smokers and thus take it as an indicator of numbers? We can't, unfortunately. It could have been that they opened the survey and realised they weren't eligible because they hadn't used shisha in Birmingham. It could have been that they opened the survey and thought, not for me. We don't know. But we were... Yeah, we did sort of tussle with how do we convert those numbers of people viewing this survey into an actual response. And then we looked at maybe participant incentives, which we didn't use because of the dangers of then fake responses, which has become a thing. recently. So we can't infer that. Chris, do we need to train GPs and nurses to ask more clearly about different types of tobacco use so that shisha use is more accurately recorded? I think we do now. It's a very clear behaviour that comes with its own health risks, and again, depending on usage, potentially more harmful than some of the types of tobacco use that they are currently capturing. So, and that's the training piece for healthcare professionals now. This is a joined up system, and it's about supporting the users by having the right support embedded within the systems, and they are going to be absolutely key in this moving forward. So yes, I would say so. We've got Sharifa, you're a nurse in the UAE. Many people believe shisha is safer than cigarettes because it's smoked through water. How can public health campaigns effectively address the misconception? So those recommendations can speak to that. There's using the environmental prompts to raise awareness. That will also facilitate discussion. And you're right, one of the biggest drivers of one of the misconceptions around this is that, yeah, it's fruity. It's got all these positive associations, and so those health campaigns, they can be peer-led, they can be community-led, they can be online, and that's the tailoring piece as well in terms of how it can be done. But the message is clear, misconception, what you're trying to clarify is clear. How you then communicate that will be through a tailoring process, depending on your users' needs, and that will vary if they're the young children, if they're the older, 5+, 40-something-year-olds who've been using it for 5+ years. It's that kind of tailoring piece that will need some thought. And we were on to last minute, so discussing comes out in the community with those. So looking at Farida's comments, I think you were responding to Sharifa there. I agree. And if we have outlined the next steps based on the findings, that I'm going to hand over neatly, thank you, Mary, to Abby and Natalia. So in terms of those next steps, over to you, Abby.
Thanks, Atia. So I think we're at the point now of thinking, what are those next steps? And I think what's become clear here is there is definitely a piece around that risk perception, but we are at that stage. So this is where I guess I'd open it up to people on the call if there's opportunities to maybe think about where we go next, where there may be opportunities to collaborate across the system. We'd be very open to having those discussions, but I think there's definitely some great avenues here we can explore based on the findings. Fab. Okay, actually perfect timing. It's now 1 o'clock. So just to say again, thank you to Professor Atia Kamal for coming and going through those findings. Hopefully everyone's found them useful and interesting. I've popped my email in the chat, so if you would like a copy of our report or the slides, we can send that to you. And just to say, thank you very much for everyone for attending.